Hello and welcome to the EMS Handoff podcast. This is David, and along with my co-host Eric McCullough, and the fancy for all those watching YouTube right now. This is absolutely marvelous. This is one of those things that we can just take everywhere. And right now we get to watch Bradley Dean stuffing his face after celebrating this evening. So it's just us tonight, and this is going to be absolutely marvelous. I don't know. We're just going to have to go because his mouth is half full right now. Bradley Dean, what's going on, my friend?
Well, so if you've watched the Facebook post, lots of water rescue over the last week with classes and stuff like that. But tonight we're going to talk about a serious clinical issue. So hold tight. And let's turn it over to
Eric. Oh, man. Well, I'm waterlogged, literally vacuuming water out of my car, trying to get it out. My kids throwing around in the mud puddles. That's pretty fun. I kind of like this. This is a cool age where I get to jump in mud puddles, and I have an excuse for it because I got two little ones. And other than that, just being, I tell you what, I took that second shot, the second COVID vaccine shot. And I'll tell you, that knocked me out for 3 freaking days. Like, it would knocked me not out. I wish I was out. I wish I was asleep through it all. The only way that I can explain is like, I must be allergic to everything under the sun, including this stupid vaccine. So, but I'm glad I got it. I wasn't happy with the side effects, but I guess it'll keep me from being hospitalized since I'm around literally swimming in Delta variant here in Middle Tennessee everywhere.
Yeah, so for those of you that were watching the previous episodes where he said undisclosed.
Yeah, I disclosed it now. Well, I did that because I kind of wanted to see where everybody was on that. And I wanted to be the one like, I'm not going to really say it just yet because when people watch the stuff, I don't want them to have any construed idea, where you have one person who did, one person who didn't, one person who just didn't say anything. This way, right. It kind of seemed balanced.
So for those of you that are watching, 2 daughters, one vaccinated, one unvaccinated. One is positive with it that was unvaccinated now. And she called me the other night begging me to take her to get the vaccine. I told her it was too late. The other one, 2 days, she was sick, bounced back, no problem.
Well, I have to, as we're talking about this, I had the wonderful privilege of having the first vaccination and then turning around and ending up COVID positive 8 days later. So was very blessed in the fact that I had a very mild case, a little cough, a little fever at the beginning, pretty much asymptomatic other than that. So now just having to adjust the second vaccination. My wife just got her second one yesterday, as a matter of fact, last evening. So she's in the midst of that aspect. So we'll see how things go the next couple of days. But, so all of us are going. We had Hurricane Ida come through. We actually had some good plans for this for this recording. And I will tell you that we've got a great episode coming up next week as well. But Hurricane Ida coming in through Louisiana. So keep in mind the EMS, police and fire down in that area as well. And really, anywhere from there on up, because as these storms have passed through, as Eric was talking about, there's massive amounts of water coming through. And it's even going on tonight. So there's a lot of people out there working, catching people, search and rescue, etc. So while this is going out, especially with the fact that it's disaster preparedness month, we want to keep our thoughts and prayers with everybody out there and staying safe. So before we get into our topic today, we certainly want to thank our podcast partner, the Journal of Emergency Medical Services. They've been a tremendous partner to the EMS Handoff since we've been started. Since we've been started. That's really good English there, Eric. You're gonna have to find someone that can do this a lot better.
Maybe Bradley. He's the sophisticated suit wearing guy tonight. He's got it. he muted. That's why I said it, because I'm like, he can't come back with a retort quick enough.
I was just gonna say, since we done been started,
So since we done been started. So anyways, since we've started, JEMS has been an excellent partner. So make sure and go by and visit them at jems.com. Not only can you keep up with everything they have going on to keep the industry informed, you can also check out all of our previous episodes, as well as the fellow podcast partners on the EMS Today podcast. You can also find us at Apple, Google, and Spotify under the EMS Today podcast from JEMS, as well as find us on YouTube under the EMS Handoff. I'm actually got on. So Bradley's sitting here in this nice suit. That's not, he's not wearing the Pursue apparel tonight, but I do.
I got mine
hoodie on, and Eric has got the subdued black. But don't forget to go by the Pursue Company and find our latest line of EMS Handoff merchandise. You can find them at thepursueco.com and find us under shop/affiliates, and you'll see the
I'm wearing it as my underwear.
Oh, there you
Bradley has gone straight Superman. Clark Kent is going to come out of the telephone booth after he's done eating. So so it's just us tonight, and we're going to get into a little bit of nitro, to nitro or not to nitro. That is the question. Trying to go a little Shakespeare there, and I'm not sure how well. So,
well,
not to be.
Hold the nitro.
Hold the nitro.
Actually, don't hold the nitro.
Yeah, I was gonna say. Well, we can
Just
we'll banter about it.
All right. So, Bradley, this is one of your topics here. Let's go ahead and get started tonight.
So, what better to start with than a quick case presentation? So the whole thing is this is actually a case that I had. I bantered back and forth with my partner, and we went back and forth, and I won. My partner and I talked about it afterwards. We went back and forth, and really the patient benefited. So I did a quick informal thing over the last couple of days to ask paramedics, should you give nitroglycerin with an inferior MI? And I bet that 80 to 90% of them said no. And then the other one said, I'm not doing it without an IV. So let's look at this. So
hey, before we do, Eric, have you taken a look at this? Because it really sounds a whole lot like Bradley Dean right now. 56-year-old male sitting at a table in a kitchen.
wait.
I was man, I'm glad you got to the joke before I could. Good.
And look what he's eating.
Oh, look.
Yeah, that's what I was gonna say. Like, he's eating like fermented bacon, and I think the healthiest thing he's got is the caviar. So he is the case study.
The only thing is it says residence, so we'll change that to restaurant and get to it. So, all right, tell us about your story, Bradley. Let us assess you.
So actually, can you just pull up the stuff and we'll just start with that? If you want to share your stuff. So basically, at 2041, we arrive to find a 56-year-old male sitting at a table in the kitchen complaining of chest pain and some discomfort. And he states that he didn't feel good the night before. EMS was at his residence because he didn't felt like his heart was beating fast. But he went to the hospital in his personal car and then was discharged from ED around 6 o'clock that morning. But so we get to him at 2041, and he's diaphoretic. Radial is weak, but he's got pulse is about 70 beats per minute. Blood pressure is 142 over 78. Pulse ox is 94%, but he rates his pain at about a 9. So this guy just meets that classic presentation. One thing I want to make sure people understand is you cannot fake diaphoresis.
So it's interesting you mentioned that right there. I always use the example from NCIS, and all the students that I've been in their classroom, they'll know this, but the very initial episode of NCIS called Yankee White, when one of the characters that subsequently became an NCIS agent was a Secret Service agent, and they were on the aircraft. And Gibbs ended up pushing her into the lavatory on the plane to tell her some bad news. And when he gets done, he uses different terminology, but he goes, "You can't fake white." And he's looking for that physiologic reaction in the body, because you can fake everything else. You can have a surprised face. You can say, "Oh, I've got a pain of 14," but it's that sick, not sick look. So
I mean, he looked sick. So I looked at my partner and said, "Put on the 12 lead. While you put on the 12 lead, I'm going to go ahead and get a patch to the hospital." Because I was preparing to do a STEMI notification. He's like, "How did you know so early?" Well, when you can't fake diaphoresis. So.
Yeah. Okay. So, I mean, I'm just looking at the case study. And again, it's easy to Monday morning quarterback a paramedic. Like, I kind of I would like to remind people that we live in a completely different world environment than hospital, than clinical medicine. Our decisions are a little different for different reasons. So as you walk in, you see a person that's sick and you don't have all this information. My immediate go-to is, well, crap, they're pale, they're diaphoretic. My immediate thought is, man, they're probably hypotensive, but if they don't need immediate life-sustaining, stuff to the ABCs, then yeah, the 12 lead gets in, and you got a STEMI alert going. So great. What findings did you see on your EKG?
Well, the interesting thing here is his radial was weak, but his blood pressure was fine. So I mean, that's an interesting thing. So David, go ahead and let's flip to the 12 lead so everybody can see that.
Ooh, 2, 3 AVF.
V4, 5, and 6 too.
Yeah.
Yeah.
So then we start looking at the other. I mean, look at 2, 3, and AVF.
Then you have reciprocal and AVR, AVL.
Yeah.
Mm-hmm.
So when I start looking
B2,
at AVL, I'm like, there's no way to fake any of that. So then I look at V6. I'm like, oh my, this is an inferior lateral, but his blood pressure is fine. And when you look at the ST segment elevation, I don't see it higher in 2 than in 3, which that's kind of a key thing when I start looking at right ventricular infarcts. If I start looking at that and I start to see ST segment elevation higher in 2 than I do in 3, then I'm worried about right ventricular infarct. I don't even have to do V4R. If they're borderline hypotensive and I see higher elevation in 2 than 3, if you listen to Tom Boulier or any of the others, that's one of the quick things that you'll pick up is this guy needs reperfusion, and we know that early in the process. So as soon as my partner was put it on, I had the patch to the hospital. I did a STEMI notification. We're probably a good 30 minutes from the cath lab at this point.
So when you patch in, do you let them know?
Just so you know, the age is wrong on this 12 lead, but that's okay.
Okay. Well, when you patch through, did you tell them it was an inferior MI, or do you just tell them, hey, STEMI alert, or do they ask for specifics?
So I told them STEMI alert, and I mean, they did come back and they asked, so what do you see? And I said, we got elevation in 2, 3 and AVF. The patient's hemodynamically stable. It's probably an inferior lateral. So we're going to see in about 30 to 35 minutes. And they were like, great.
So going from that, what was so you got the EKG, you got your vitals, you got your axis. Looks like there's no significant axis deviation. Well, yeah, actually there is axis deviation, but anyways, so you got them going.
It's not bad though.
But it's not bad. Yeah, it's nothing I would consider pathological. So what was your next? Well, I guess what was your treatment for this guy?
If you don't mind, before we even get there, Bradley,
go ahead.
Was there anything other about his history, or was it pretty much unremarkable?
So his history was pretty much unremarkable.
So allergies, no meds.
Nope, no allergies, no other meds. I mean, he said that he had a couple of things. So as part of my assessment, I'm sitting here and he's at the kitchen table. So one of the first things I did was I kind of looked at his lower legs because I wanted to see if he had any, hair on his lower legs. And, so he's wearing shorts. So I kind of look at his lower legs and I noticed that down toward his ankles and about midway up his calves, he didn't have hair. So he had minimal hair in lower extremities, which immediately tells me he's got peripheral artery disease, and peripheral artery disease equals coronary artery disease right up front.
Okay. So he could have just had a non-diagnosed history because of whatever reason.
Right. So non-diagnosed history. So we know we got an issue. And the night before, very important here, is he encountered EMS because of an increased heart rate, which may have been a precursor. But his 12 lead the night before was normal. He went to the hospital. His troponins and everything else were normal. Got discharged about 6 o'clock in the morning. They did try to schedule him for a follow-up, which he refused.
Okay. So he's had symptom migration then for the past, and I think this is an important part of like the whole patients who don't have ongoing signs of ischemia and their 12 leads still need to be transported or, convinced. I mean, I'm not saying the crew didn't do their due diligence on that. I'm sure they did. To let them understand that like they need to get monitored for 24 hours because, his troponin levels, his CK and B could have been elevated, his cardiac panel could have been elevated.
Right. So, I mean, even if you did his heart score minus his troponins, he was scoring somewhere around a 6 or a 7. So while we don't have time tonight to go into the heart score, I would encourage every paramedic to look up what the heart score is because, we can do everything in the field minus the troponin. And if you take that out, they've got a score of 6. I mean, they're at high risk for cardiac stuff in the next, 24 to 36 hours.
All right. So we got this part. At this part, you're like looking at this. I'm looking at the EKG going, oh crap. Well, this guy's definitely, and you got an awesome monitor. It even tells you inferior ST elevation. That's great. You have a good monitor. So I like those. I don't like, I've never understood why people are like, don't take what the monitor says. But I'm like, but if it says something, you might want to at least look at it and verify what it says. It may be completely wrong, but it's kind of nice to have a little bit of a helper there.
So even if this is a brand new monitor out of the box, and it says meets ST segment elevation MI criteria, I don't care if it's a Philips, a LifePak, a Zoll, anybody else. If it says that, there are 70 to 80% specificity with that particular thing if it sees it.
All right, so that's a good argument enough to say you probably ought to verify that or at least take it into consideration. Don't just like toss that over to the side. No, that's really good. So what was your immediate like priority once you got that 12 lead? You got the STEMI alert, now you got this guy loaded up. So
while he was actually doing the 12 lead, I had the first responders, let's go ahead and get his aspirin on board. I did the STEMI alert as soon as I saw this, turned around immediately, went to give him nitroglycerin. My partner was like, that's an inferior MI. You want an IV first? I'm like, well, he's hemodynamically stable. So he kind of looked at me. He agreed, but he was a little reserved. We went ahead and gave him nitro, got him loaded up, got him to the truck. We didn't spend a whole lot of time with this guy on scene.
Well, I think, it's kind of interesting. I go back to even my, even what we had at the time was called the MTIV here in the state. It's been many years ago, but we could administer nitroglycerin. And, one of the things it was pretty much just the fact we didn't have any of the diagnostics that anytime we were giving nitro, unless we just had a superb blood pressure, we needed to have the IV. So we had to control. Now, putting that in conversation here, as long as you've got good pressures and you have the material available in case it does go south, and that's part of what we're talking about here, but then go with it. So you go with 324 of aspirin and then 0.4 sublingual nitro at that point. So just out of curiosity, any breath sounds beforehand to see if there was any fluid, and is there any signs of peripheral edemas?
No, no signs of peripheral edema, clear breath sounds. So you bring up an interesting point. So in North Carolina and, various places across the country, if the patient's already prescribed nitroglycerin, so this patient wasn't, but if the patient's already prescribed nitroglycerin, it's within the scope of practice for an EMT to give nitro. But I hear paramedics all the time say, I'm not giving, I'm going to do a 12 lead. I'm not giving nitroglycerin until I get an IV. And I tell them, if the EMT can do it without a 12 lead and the patient's having chest pain and they're hemodynamically stable, systolic blood pressure above 100, you take the paramedic out of the equation, the patient gets treated.
Right.
Yeah. And I mean, patients are given nitro all the time, and they don't have IVs. They don't have 12 leads. They're just told, hey, if you get chest pain, just pop one of these. And if it settles down, great. If not, then you need to call 911. So, I mean, patients are
they're being told to take up to 3.
Yeah. Yeah. They're already doing this treatment recommendation without that. In fact, I had a paramedic one time. She was a brand new paramedic. I felt bad for her because, typical EMS old school leadership, instead of helping her, browbeated her about giving nitro to somebody without an IV. And I try to tell her, I'm like, man, you did 3 IV or you did 3 nitros. You couldn't get an IV. Why did you keep giving the nitro? She said, because he was still in pain. But his blood pressure was fine. I'm like, I don't see a problem with that. I mean, I feel like we have a good. The bad thing about EMS is we're still a young profession. So the voices of the older generation are a little bit stronger, and the anecdotes that come from those generations tend to be a little bit more sticky. So the boogeyman of hypotension with nitroglycerin, I have not seen a lot of studies that have those outcomes, because from what I have read, hypotension is a severe hypotensive reaction to nitroglycerin administration, regardless of etiology and pathology of ECGs, of MIs, is really anywhere between 12 and 23%, depending on which study you read.
Yeah, and I think we may have a link to a couple of those studies, in the show notes. But one of the big things is these patients need reperfusion. The only way to reperfuse is to stop the platelet aggregation, get nitroglycerin on board so the body converts it to nitrous oxide and dilates those vessels so they reperfuse. If they are normotensive, there's not an issue. If the patient becomes hypotensive, stop the administration of nitro.
Well, going back to Eric's statement just a second ago, as far as the multiple repeat doses of nitro once you get past 3, one of the things, and as we get to the next where we kind of go through some of this, it was identified, we need to start looking at some other ways for pain management as well, because we may not be dealing with, something that the nitro is going to be giving a response to. So, we do need to take that into our consideration that, 3+ nitro, we still keeping a good blood pressure, but not eliminating the pain. What else could it be? So within 5 minutes, you get a STEMI notification after your 324 of nitro and 0.4 or 324 of aspirin, 0.4 of sublingual.
Right. So if you flip to the next page, next slide. A little too far. There you go. So, as we're getting the 12 lead, we go ahead and get the aspirin on board. Then we immediately turn right around and give the nitroglycerin. We do the STEMI notification. I get another blood pressure. It's 138/76. He rates his pain at 8 to 9. So I'm like, let's get him moving. So we get him loaded up, move him outside, get him in the truck at 20:51. I'm popping another nitro while we're getting IVs. So we get a 18 gauge in the left AC, we get a 20 gauge in the left hand, and we get on the road because this guy needs reperfusion. So we transport him routine to the closest cath lab, And I'm thinking, well, I don't want to drop his blood pressure, but at the same time, I do want to relieve the pain. So I give 75 micrograms of fentanyl IV. So the reason I chose a fentanyl versus morphine is, morphine works off of the histamine response, which causes a change in blood pressure. So I'm trying to relieve the pain without changing the blood pressure, and that's why I chose the fentanyl.
Did he ever get nauseated during this? Because yeah.
So truthfully, the answer is yes. So he got nauseated about the time I was doing the next blood pressure. So this is not documented on here, but one of the things I will say is I let him smell some alcohol prep pads. That's a whole different discussion.
Yeah.
But
well, and that's what I wanted to bring that up, just because you can expect nausea as a result of either the ongoing MI, it could be the nitro, it probably isn't the aspirin. It takes too long for it to kick in. Because I don't know if y'all remember about, that used to be concurrent. We used to give either Phenergan or Zofran along with the aspirin and the nitroglycerin. And that kind of went away. But morphine used to be the helper, because then you could give Phenergan and morphine, because Phenergan potentiates the effects of morphine. But I was just curious about that, because nitroglycerin tends to have that impact, and I've seen that anecdotally with patients in the abdominal complaints.
Yeah, so about 2053, 2054, he complained a little bit of a headache, a little bit of nausea. So basically, while it's not documented here, I opened up some alcohol prep pads and I let him smell those, and that took care of his nausea. I know some people are probably turning their heads sideways listening to this, but it works.
That's a good trick. Yeah. I mean, even if it's a placebo effect, that's awesome. It's still not a drug, and that's good.
But there's some research behind that, and maybe we can get David, who's done some research on that, on sometime to talk about it. But
so what about you're about to work into that third and final dose of sublingual nitroglycerin, and then you have here nitroglycerin paste. So it's interesting, because according to everything I've ever heard of from people, this person should have dropped their blood pressure to 80 over 48, and because they're having an inferior MI, dadgummit.
Right, and he maintained, which was interesting, because a lot of these patients do have the possibility of dropping that, but it depends on whether it's a proximal or distal occlusion. And while we don't know exactly where his was, I never did the right side, because he was hemodynamically stable, and I wasn't going to waste any time. So after the second dose of nitro, no change in the blood pressure, I'm figuring this is probably more of a mid to a distal occlusion. So I went ahead with my third nitro, put on some nitro paste. His blood pressure remained fine. I think I went ahead and bolused him maybe 500 cc's of fluid, because any patients going to the cath lab, they're going to need to clear that dye anyway. So, 500 cc's, because most people are dehydrated, it's not going to hurt them. And, even after that half-inch nitro, he remained hemodynamically stable. He did have another drop in his blood pressure, but the lowest was 125 over 66, but we got his pain down to a 3.
I was curious, and I haven't really ever gotten a really good answer over this, and I can't find any good research on this. So we know nitro clears out of the system pretty quick. I think it's like 4.5 minutes, which is why you're supposed to be every 5 minutes at least, at the bare minimum. But why is it only 3? Why not more than that? Why not 4 or 5 or 6? I just never understood. Like, if you still have 20 minutes of transportation time, how come you can't do more?
If I've got 20 minutes transport, most protocols are going to say 3. I'll call and say, hey, I'm either going to switch to nitro paste, or would you like for me to continue dosing every 3 to 5 minutes? I'll talk to medical control, consult with them. And usually I will begin working the whole thing in with fentanyl. Even, keep in mind that nitroglycerin is not an analgesic, but the effects of it help relieve the pain because of the vasodilation. And that's what we're trying to achieve is we've got to get blood flow through that occluded vessel in order to reperfuse the heart, or hopefully preserve what we can until we can get them to a cath lab.
Well, that's kind of what I was going at earlier. If we've got 3 nitro already delivered to the patient, sublingual nitro delivered to the patient, even no matter where that occlusion actually exists, we have to kind of take a look at whether it's working or not, and take a look at some of the others. Part of that is as we see all this, the oxygen demands as the person is in pain, the effects end up increasing because of the anxiety, the breathing, and so the demands on the heart increase, which increase that pain. So here, I would honestly say that it's a combination of both the fentanyl administration as well as the nitro that started to relieve his pain, because he probably started to calm just a little bit, if I would venture to say, as you got to the 25 mics of fentanyl, after having the 3 nitro and the sublingual or the nitro paste administered. So he's probably calming, which is calming the demands on the heart, which allowing whatever blood flow is getting through to do more.
Yeah, and the main thing is we've got to do whatever is in the best interest of the patient. And I will tell you, the only reason that it took me that long to go to the half-inch nitro paste, because I just didn't get it out. I should have done it earlier to begin that process of doing that continual absorption to be able to get that in there. And he could have tolerated an inch if I'd have done it sooner.
Right. So ultimately, you end up getting this patient down to a pretty much a resting comfort level. And this is the other thing is we're not necessarily looking to make everybody pain-free. He's down to a tolerable level. His pressures are still good. 6 minutes later, you get to that emergency department. And then your cardiology consult's already there. I'm assuming because of your STEMI notification at the beginning, so that the cardiologist is going to meet you in that emergency department.
Yes, and the only reason the cath lab was not ready is because they had a staff member that wasn't quite there yet, because their page from my initial STEMI notification at 2046, the hospital didn't page it until 2052. Which was actually about the time we actually began that transport. So there was a slight delay there, which that happens. And then they typically have 30 minutes. And for whatever reason, this person got caught in a little bit of traffic at the mall, because this hospital is right at a mall, and they got there a few minutes late.
I think that's something important to consider too. In the time of coronavirus, where you might have staff shortages and stuff to think about, so reperfusion definitely starts before the hospital.
Just out of curiosity, I'm pretty sure, but you all have capability to transmit your 12 leads, so they already had your initial.
Yeah. So they had the initial 12 lead, and they actually got that 12 lead in the middle of my STEMI notification. That's when they called back and asked me what I had, and they said, we copied that. We got a copy of your 12 lead. Thanks for the early notification.
Okay. So ultimately, he goes to the cath lab, probably still replaced. What is the outcome of this guy?
So while I don't have it on here, at 2045, they actually had access. And then at I don't want to say it was 2150 something. I don't have the numbers in front of me. They actually were able to cross the lesion and reperfusion to happen. So roughly an hour and 10 minutes after the 911 call.
So just out of curiosity, afterwards, do you all have I keep going back to the old school term, morbidity mortality conference. Do y'all have a post-incident refresh with them?
So in this particular case, the answer is no. We did not. I did talk to the cath lab manager only because of other professional relationships that we have, and she gave me a quick update.
So kind of the whole conversational point that we've had here has been the fact that we have an inferior lateral infarct, and the question is whether we give nitro or not. So in taking a look, you kind of back this up at the very beginning, and we've mentioned it a couple of times throughout that basically we're talking about the fact that if we all were EMTs on the truck, we would have it within our protocols to go ahead and administer the nitro. So what is the difference between adding that 12 lead in there and looking to take that nitroglycerin out?
I think the difference is bad paramedic instructors. And I hate to say that because everybody's had that one patient that, you know, kind of crashed after you gave nitro, but nobody can tell us who that patient was. Well, you know, somebody that knew somebody that knew somebody had that one patient that crashed after they gave them nitroglycerin. So if you look at it, and 60% of those patients that crash afterwards would have coded anyway. And there's lots of data and stuff that's out there that kind of shows that. So what we've got to do is we've got to look at the hemodynamic stability of the patient when we first encounter them. If their blood pressure is above 100, let's give them the nitro. Because the whole thing is if you do that, you begin that reperfusion process, they're going to support their own blood pressure. If that blood pressure changes after that first administration, or you see ST segment elevation higher in lead 2 than you do in lead 3, hold the nitro, get an IV, give them a fluid bolus, and then give them the nitroglycerin. Either way, they're going to need that nitro.
Yeah, I think it's all about patient-oriented outcomes. You know, not anecdote, not it's about the patient outcomes. And so, like we were saying before, these patients would have prescribed nitro anyways, and if they're having chest pain, they'd pop some nitroglycerin without even considering their blood pressure or an IV or their 12 lead or anything like that in the first place. So, and I do think it's good you absolutely should critically think and have the best point of care would be having all the stuff. Like, I don't think you should blindly as a paramedic just give nitroglycerin without getting a 12 lead. I think you need the fullest picture first and then make that decision. But you don't have to be scared about the inferior MI.
So ultimately, in this, you had an example of yourself sitting there at the restaurant having chest pain as you enjoy your meal.
Mm-hmm. And bacon.
And bacon.
And bourbon.
And
wow. Just keep on with it.
And then, so, you know, I think it really does, you know, this kind of talks about the conversation with the docs last week with Dr. Holly, and when we got into some of the pitfalls that they see from pre-hospital care is, you know, the documentation, and Dr. Holly basically like, you know, if you've got something that you know is going to work, and, you know, we kind of take a look at a lot of different things that, you know, they're prescribed for one thing and the physicians have an off-label use for them. You know, one of the things I know, and this actually came from experience in the field, you know, we always talk about checking and assessing for erectile dysfunction medications. And, you know, between Viagra, Levitra, and Cialis, and, you know, going between 24 and 72 hours. But there's actually some of those treatments that are now being used as a daily dose, not for erectile dysfunction, but to limit swelling of the prostate. And so now they're on a regular dose. So you say, hey, do you take erectile dysfunction medication? And they say no, because they're thinking about something else. So all of these, you know, all the treatments are there. The idea with the chest pain here, and I completely agree with Bradley, you know, you're presented with that sick patient, you can't fake the look. You could fake the again, the facial expressions, etc. But when you see somebody pale and sweating, it's almost impossible to mimic that without the body doing it. You've got to act. If not, something's going to happen. Everything else presents right in line. The one thing I personally would say is that I would take a look at the fact that I would, listen to those breath sounds as well. And you did. The concerning thing is the difference between the blood pressure and the radial pulses. The radial pulses being weak, even though while the blood pressure is good. So ultimately, it looks like the outcome ended up extremely well. But critical thinking is the key to this case, right?
Right, and I think the reason for the poor radial pulse, was kind of echoed by looking at his legs and his feet and seeing that he had poor peripheral vascular disease. So that might be part of it.
Right. All right. So as we went through this case, go ahead and give us your last thoughts, Bradley, since you brought this to us.
So don't just hold the nitro. Make sure you do a good assessment. If the patient is hemodynamically stable, then make sure that we go ahead and get that aspirin, get the nitroglycerin on board, do your 12 lead early. And for those that are listening that just finished the paramedic class 2021, congratulations. So those are my final thoughts.
And how about you, Eric?
Well, pretty much same. Hey, congratulations. Don't overthink, but don't undertreat as well. Use the options that you have in front of you. Take a moment. There's very few times that you're going to have someone who's literally going to die in the next second if you don't do something. You have plenty of time to make a good decision, and if you're not ready to make that good decision, then get in the place to make a good decision, even if the decision is doing nothing at all. Just make sure you have a good reason for it.
Like Dr. Holly said, some people need a 45 treatment to the head, and if you justify it to them. So mine is kind of along the same lines as well. As just because you have it doesn't mean you need to use it, but just because you're scared of it doesn't mean you need to withhold it either. So there's a lot of people, when we put new stuff on the truck, they like to go for that. So you talk about fentanyl and some of this other stuff. It's like, back up, treat the patient well, get your assessment, and move on. Don't be scared just because you've been told. Again, we can what if a scenario to death. So anyways, I think this is a good case, and we'd love to hear all of your all's feedback about it as well. So make sure and go to our Facebook site and give us a comment. Let us know what you think, how you would have potentially treated different, and we'd love to hear your opinions. Don't forget to go to our website that Eric has been working on, emshandoff.com. Don't forget to go by our podcast partner, the Journal of Emergency Medical Services at JEMS.com, and go by the Pursue Company and check out all of our awesome swag there. They deliver directly to you, whatever you want to get. The Keep Back podcast line has been one of our most popular, but getting ready to go into winter, we've got the hoodies, long sleeve shirts, whatever you so desire. So on behalf of Eric McCullough and the fancy Bradley Dean this week, this is David. Take care, stay safe, and always remember the value of your EMS handoff.